Hello everyone, welcome to Patho Excellence. Today we are going to discuss histopathology slide microscopy for general pathology, and in these are some of the important slides which are important for exam. So we discuss all these slides one by one. So before we start, let's see what is the stepwise approach to microscopy. As you all know, there are four type of lenses in microscope. So this is 4x, this is scanner view, 10x low power view, this is 40x high power view, and this is oil immersion. So in histopathological examination, we are going to use 4, 10 and 40x. So there is no use of 100x in histopathological examination. Now what is the use of scanner or 4x view? So it is for orientation and survey. We have to focus slide under the 4x objective and we have to identify which organ is this. And with the help of tissue architecture, we will look for overall pattern and distribution of lesion, and with the help of this scanner view we can easily identify where the lesion is located because the wide field is visible with this 4x view. And here there is no need to diagnose at this stage because this is generally for the organ identification as well as location of lesion. Now use of 10x, it is for pattern recognition, and here it is where we have to identify what is the area of interest. So here we have to assess with the help of this 10x architecture distortion, inflammatory infiltrate present or absent, is there any necrosis, congestion or fibrosis, so that we can identify which type of lesion, whether it is inflammatory or degenerative or malignant or necrotic lesion. So this will help us to narrow down probable diagnosis. Now third important is high power. This is 40x. So under the 40x magnification we can easily see cellular details. So here we can identify what is the type of cells, whether it is neutrophil, lymph or macrophage, what is the nuclear change, we can identify whether it is pycnosis, karyolysis or cytoplasmic changes like fat vacuoles or granularity. So with the help of this we can easily reach to the diagnosis at cellular level. Now when you see thoroughly the slide under all these four magnification, then how will you write your microscopic diagnosis? So this is the standard format. When you see the slide, first of all, write down which stain you are seeing. Means commonly histopathology slides we are stain used is hematoxylin and eosin. Second, write down which organ you have seen, whether it is kidney, liver, lung, so that you can narrow down the diagnosis. Now, important, what are the microscopic features you have identified using all three types of lenses, and finally your diagnosis, which includes microscopy is suggestive of this diagnosis, right? So now let's begin with the important slides. First is here is cloudy degeneration. Now under the low power or 4x or scanner view, you can identify this is the organ which is showing glomeruli and tubules. So organ is kidney and stain is H and E. H hematoxylin, E eosin. Eosin will stain cytoplasm and hematoxylin will stain nucleus. So eosin or pink color is for cytoplasm and blue is for nucleus. So here these are the glomeruli and these are the tubules. Now here in the tubule you can identify the clearing of the tubule. So you have identified organ, you have identified what is the stain, and now you have identified that there are some cytoplasmic clearing or cloudy change in this tubule. So these are the tubules where you can identify nucleus easily, and this is called cloudy change, which is either vacuolated change or granular change. Now you have to write down what exactly microscopic features you have seen. So here you can write down the cells of tubules are swollen, cytoplasm is either pale, cloudy or granular, right? Then there is loss of cytoplasmic transparency, nucleus is centrally placed and intact. This is suggestive of reversible cell injury, because in reversible cell injury nuclei are not affected, but in irreversible injury there is loss of nuclei. So this is a type of reversible cell injury, and here the cytoplasmic membrane is also intact. So this is glomeruli, and these are the affected tubules with cloudy change. So your final diagnosis is these microscopic features are suggestive of cloudy degeneration. So these are some Viva questions which can be asked in your exam. So what is cloudy degeneration? Why does this cloudy appearance is visible? So all these questions are important for the Viva. Now second slide is fatty liver. So fatty liver, as the name suggests, there is fat presence in the cytoplasm. Another name is the steatosis. So here you can first of all start with scanner view. You identify whether this organ is liver or not. If you identify liver, you can easily identify these are the macrovesicular fatty change in the liver. So these are the normal, or you can say viable hepatocytes, and these are macrovesicular change in which nucleus is peripheral push and fat globule present in the cytoplasm. So this is macrovesicular change. Here these are some tiny vacuoles are present in the cytoplasm. So these are called microvesicular fatty change. So there are two types of fatty change, microvesicular and macrovesicular change. So now you can identify liver, stain is HNE, and for organ identification in liver you can easily identify, one is portal triad and second is central vein. So central vein and portal triad are helpful to identify organ, and this is the section shows here a macrovesicular and microvesicular fatty change. So microscopic features, you can see hepatocytes show clear vacuolar change, vacuoles represent fat droplets, and this will lead to nucleus push to periphery, and these are the macrovesicular steatosis because majority of the vacuoles are larger in size, and all the sinusoids between this hepatic or hepatocyte plate is compressed. And what is the special stain for fat? That is oil red O. And in HNE stain, why these vacuoles are clear? Because fat cannot be stained with the hematoxylin and eosin stain. During the staining procedure, we are using different types of alcohol. So that will lead to washout effect on the fat, and all fat is wash out. So you cannot identify this fat with the help of HNE stain, but you require special stain which is oil red O. So here your diagnosis is microscopy suggestive of fatty liver or steatosis, and these are some important questions for Viva. So you go through this, and uh, this will help you to remember microscopic as well as pathogenesis, etiology, all the factors related to fatty change. Now this is the slide of myocardial infarction. So here in general pathology you have to remember what is infarction. So infarction is basically a tissue cell death due to ischemia. So here it is coagulative type of necrosis. Here these are the cardiac myocytes, and here the infected area is present. Here you can see this is the homogeneous pinkish area which is devoid of nucleus in some of the areas. So this is one type of necrosis where nucleus are destroyed, and this is coagulative type of necrosis because the cell outline is visible. So organ is heart, HN is stained slide, and here the infected area, and these are the viable heart muscles or cardiac myocytes are present, and this is the area of infection. So microscopic features, it is a type of coagulative necrosis. In early stage means early acute MI, you will find waviness of uh, fibers of cardiac myocytes, eosinophilic myocardial fibers, and there is loss of nuclei. So here you cannot identify any nucleus in the myocytes, and in between these fibers you can identify plenty of polymorphs. So this is acute myocardial infarction. And in previous slides we have seen fibrotic area or pink homogeneous area where it is called healed MI or myocardial infarction with healed change. So these are the some of the microscopic and gross changes according to the time of ischemia started. So when you learn systemic pathology and heart chapter, then you have to remember all these differentiating point according to the time duration. So this is microscopy features are suggestive of myocardial infarction. So your final diagnosis is MI. Now, see, these are some important questions. So this is ischemic necrosis, coagulative type, and neutrophils are hallmark for the acute MI, and this is due to atherosclerosis and sometimes thrombosis. This is type of necrosis, so cell death is there, and TROP-I, CKMB are important enzyme markers for MI. Now, fourth slide is tuberculosis, either lung or lymph node. So, first of all, under the 4x view, we have to identify whether this organ is lymph node, lung, or any other organ. So, here in this section, you can identify some of the alveoli visible here. So, this is a section of lung, but in 4x, in 10x or 40x, you can identify these are the giant cells. So multinucleated giant cells, these are the Langhans type of giant cells. And in the center, this is caseous necrosis. Caseous necrosis is visible as granular pink amorphous debris, and surrounding this caseous necrosis, you can identify small tiny lymphocytes, some of the fibroblasts, and epithelioid cell. For this you require 40x view. So here in this 40x view you can identify sleeper shaped cells or stout elongated wavy epithelioid cells, some slender fibroblasts. This is caseous granular necrotic material, and these are the Langhans type of giant cells. So this is how you can identify caseating granuloma. So here this is the slide of caseous necrosis. So what exactly granuloma composed of? It is the aggregate of epithelioid cells. These are the epithelioid cells. They are plump, elongated, having abundant cytoplasm. Basically, macrophage are activated and converted into epithelioid cells, and these epithelioid cells are aggregated and they form giant cell. This is called Langhans type of giant cells. So here complete granuloma composed of central necrosis, rim of epithelioid histiocytes. These are lymphocytes and Langerhans type of giant cells. So here this is the section of tuberculosis in the lung. So your microscopic features you have to write down, like this is the slide of, or this is the caseous necrosis, or section shows caseous necrosis, presence of epithelioid cell granuloma, Langerhans giant cell, lymphocytes and central acellular necrosis along with some fibroblast and macrophages. So microscopy findings are suggestive of tuberculosis, or here in general pathology, if you can write down only caseous necrosis, then also it is correct diagnosis. So these are some important questions for your Viva. Now let's see calcification. There are two types of pathological calcification. One is dystrophic and second is metastatic. But here both these slides are of dystrophic calcification. First one, this is Monkeybugs calcification, where you can identify multiple, here the section shows multiple muscular arteries, and in the muscular artery, this is lumen where RBCs are present. So for the vessel identification, you can search for RBC. So this is lumen of the vessel where RBCs are reddish in color. In media, you can identify this purplish material present. It is calcification. So this is Monkeybugs calcification where media is involved by calcification, but intima and lumen are normal. Now this is the second example of degenerative or dystrophic calcification, where here the coronary artery is affected, and this is the large atheromatous plaque which contains calcification here. So this is a slide of coronary artery atherosclerosis. Here lumen is narrowed, and in contrast to Monkeybugs calcification, here the calcification is in the intima layer. So here media is involved affected by calcification, here intima is affected by calcification. So organ generally, when you see artery, either coronary artery or this is the section from the uterus. So these are uterine wall showing muscular arteries. So here the intima is showing calcification, here it is media. So now microscopic features for both the lesion, like here calcification in media, intima and lumen spared, elastic lamina is intact. In the atherosclerosis, this is intimal thickening, lipid core is present, sometimes foam cells and fibrous cap along with the calcification. So this is two types of dystrophic calcification. So here you can write down these microscopic features are suggestive of vascular calcification, which is pathological calcification. Here these are the example of dystrophic type of calcification. So here the some important Viva questions related to dystrophic as well as metastatic and pathological calcification. Now acute appendicitis. So acute appendicitis, in scanner view you can easily identify appendix which is having a lumen, and these are the muscular layers. So here you can see this lumen is lined by mucosa. So this is intestinal lining or mucosa, but here there is ulceration, means loss of mucosa. You cannot identify glands here. So this is called ulceration. Some reddish material, these are the RBC. So hemorrhage, ulceration as well as lumen. So these are the identification marks for appendix. So organ is appendix, HNE slide. So this is intact mucosa, and these are the lymphoid follicle, muscular layer. So this is the organ is appendix. When you see under 40X, This mucosal lining shows plenty of neutrophil. So here with the help of 40x you can identify transmural or mucosa shows neutrophilic infiltration. These are the neutrophilic cells. So they have multiple lobes. So you can identify neutrophil edema. So here a space between these tissue. So it is edema. Some of the blood vessels are congested. Mucosal ulceration. Ulceration means loss of epithelium lining. And you can also find serosal inflammation. So these are the features suggestive of acute appendicitis. And you can be asked some questions related to acute inflammation as well as chronic inflammation. Now, next slide is pneumonia. So here in this section you can identify these are the alveoli. So alveoli are lined by this type 1 and type 2 pneumocytes. So these are alveoli. Generally air is present in the alveoli. So normal lung shows clear area in the alveolar lumen. So here because of pneumonia, acute inflammatory cells are collected. So these are multiple lobated or polymorphs are there in the alveolar lumen. So here anthracotic pigment which help us to identify organ, because anthracotic pigment is seen in some of the cases in lung, and these are the alveolar wall containing plenty of polymorph. So our organ is lung, stain is hematoxylin and eosin. So here alveolar wall and lumen of alveoli contains plenty of polymorph. Now microscopic features you write down: alveoli filled with exudate, neutrophils and some of the fibrin material if you can identify. These are the alveolar septa which are congested generally and loss of air spaces. So these are suggestive of pneumonia. Now what is pneumonia? It is acute inflammation of lung parenchyma and cells are neutrophil, exudative phase, and there are 4 stages of pneumonia. Lobar pneumonia. One is congestion, red hepatization, grade hepatization and resolution. Hepatization word is because of this acute inflammation, lung consistency is converted like having liver consistency. So they are lung parenchyma shows firm in consistency. So that's why it is called hepatization. Organism Streptococcus pneumoniae and solid liver like lung, because of this it is called hepatization. Here how will you differentiate it from TB? So no granulomas in this and complications are abscess and pleural effusion. So these are some important questions. Now next slide is meningitis. So as the name suggests, meninges are inflamed due to some acute infection. So pyogenic or acute meningitis, where here in the section you can identify, use scanner view to identify brain parenchyma. So here you can identify this is the brain parenchyma and this is the space, this is called subarachnoid space. Here in the subarachnoid space some bluish granularity is identified. These are nothing but the acute inflammatory cell collection. So polymorphs are collected in the subarachnoid space. So these are congested vessels. As you know, 3 layers, outer is dura, then arachnoid and pia mater. So this is pia mater. Here it is arachnoid and outer layer not visible, this is dura. So this is subarachnoid space. So space between this arachnoid matter, and pia matter is called subarachnoid. And here, because of inflammation, there is changes of acute meningitis. So this is again high power view. You can identify this is brain parenchyma, and this thickened layer shows space between pia and arachnoid. So this is called subarachnoid space. Subarachnoid space having abundant polymorph collection in the layers, some dilated and congested vessels. So this is the section of brain. H&E slide stain. Neutrophils are seen in subarachnoid space, congested meningeal vessels, some fibrinoid exudate, and here you can identify edema. So these are microscopic features suggestive of acute meningitis. So some important questions related to acute meningitis, you go through this for Viva. Now next is CVC lung or chronic venous congestion. So here first of all have to identify organ under 4x. So this is lung. You can identify with the presence of alveoli and bronchiolar or bronchus. Now here the lung parenchyma shows these are the alveolar wall, shows thickened in having thickened appearance. So thickened alveolar space, alveolar wall, and this lumen of alveoli shows brownish color colored cells in between in the alveolar lumen. So these are heart failure cells, which is nothing but the hemosiderin laden macrophages due to chronic venous congestion. So sorry, here it is written liver, but it is lung. And here you can identify alveolar septa. Heart failure cells are nothing but the macrophage, which contains hemosiderin pigment, which are pigments are derived from the lysis of RBC due to chronic venous congestion. So you can compare, this is thickened septa, some heart failure cells, and sometimes mild or chronic inflammation like lymphocytes may be visible. So here in 40x view you can identify this is alveolar septa, and sometimes fibrosis, hemosiderin laden brown macrophages, or also called heart failure cells. And you can also find alveolar edema and congested alveolar capillaries. So these are the features suggestive of chronic venous congestion of lung. Now some questions like what is the cause of this CVC? So it is most common is left-sided heart failure and mitral stenosis. CVC liver, another slide we will discuss. It is brown colored appearance, but here because of central vein congestion and surrounding fatty necrosis. So in CVC lung, hemosiderin laden macrophages, and grossly it is brown in duration. And in nutmeg liver, first of all identify liver parenchyma with the help of portal triad and here central vein. So in nutmeg appearance, already we have discussed in previous video that dark and light spots are there. So dark spots will suggest congestion surrounding the central vein, and central vein is also congested, and light color is due to fat infiltration due to hepatocyte necrosis surrounding the central vein. So here you can identify this is central vein, portal triad, these are the hepatocytes, dilated sinusoids, but the actual pathology is here. So here central vein is dilated and surrounding hepatocytes are necrosed, and there is sinusoidal dilatation which is having abundant RBC. So it is giving red brown appearance, and surrounding hepatocytes show fatty chains, so yellowish appearance. So this is fatty necrosis or fat presence. This is congested capillaries, congested central vein, and this will ultimately lead to centrilobular necrosis and fatty changes in periphery. So these are the features of chronic venous congestion in liver. So what is nutmeg liver? It is mottled appearance, and here it is due to right-sided heart failure. So CVC lung, it is due to left-sided heart failure. CVC liver, it is due to right-sided heart failure. Now, acute tubular necrosis in the kidney. So first of all, we have identified this is kidney with the help of scanner view, because glomeruli are easily visible, and these are the tubules show necrosis. Now because of necrosis there is loss of nuclei. So nuclei are not visible, and cytoplasm is cytoplasmic membrane is not visible, and only the necrotic material with tubular outline is present. So this is the coagulative type of necrosis. And what are the causes of ATN? Poisoning and some ischemia, etc. So here this is a section of kidney. You can identify with the help of glomeruli and H&E stain, which is commonly used. And here these are the tubular cast where all the tubular epithelial cells are necrosed and collected into the lumen of tubule. So these are the tubular cast, which is nothing but the necrotic tubular epithelial cells with loss of nuclei, and only the pink cytoplasmic material is visible. So microscopic feature includes necrosis of tubular epithelial cells, no brush border is identified, tubular dilatation, and these are the called granular cast in the lumen. So granular casts are made up of necrosed tubular cells, and glomeruli here not visible, but it is relatively normal. So these are all features suggestive of acute tubular necrosis. So what is ATN or acute tubular necrosis? It is due to necrosis of renal tubular epithelial cells, ischemia and toxins. Mostly proximal tubules are affected, glomeruli are normal. In urine examination, you can find granular cast, and it is a type of coagulative necrosis. And here mainly tubules are affected in ATN, where glomerulonephritis, where glomeruli are affected. So these are some important questions related to microscopy slides. So I hope now you can easily identify your a microscopy slide under the microscope with the help of scanner, low power and 40x, and write down your findings in the standard format, like what is organ, which stain is used, and what are the microscopic features, and lastly give your diagnosis. So next topic will be another practical revision class, and thank you for watching. If you found helpful, please like, share and subscribe this channel. Stay tuned.